Romain. He is a critical care nephrologist. And colleagues from Moldova, Professor Adrian Belli, head department of anesthesiology and intensive care at the Institute of Emergency Medicine. And Professor Belli is also the president of Society of Anesthesiology and Reanimatology of the Republic of Moldova. And Dr. Ruslan Baltaga, who is Vice President of Moldova Society of Anesthesiology and Reanimatology. As well, he is the President of Valeriu Gheric Medical Foundation. I would like to mention that this meeting is organized by the Valeriu Gheric Medical Foundation in partnership with our partners from Israel, Hadassah Medical Center, as well as Moldova Society of Anesthesiology and Reanimatology. I welcome all our experts during this webinar, and I am glad to be able to start this webinar. For the audience, I would like to mention to everybody that we ask you to keep your microphones and to keep your cameras turned off. And if you have any questions, please send us the questions through the chat in Zoom or through the Facebook. So we will keep the eyes on both chats, and we'll provide the questions to our experts. For the beginning, I would like to ask Professor Adrian Belli to tell us in several sentences about the COVID in Moldova, about the epidemiology of COVID, and about the how is ICU services organized, and how ICU services defeat the COVID pandemic in Moldova. Professor Belli, please.
Okay, thank you, Ion. I'm represent Institute of Emergency Medicine, and the first our patient is we starting activity in the last day of March till today, and now we have around 40 severe patients. From there, 23 on mechanical ventilation, different modalities of mechanical ventilation. In the country, we have two big hospitals who take care of critical patients, and but mainly is from Institute of Emergency Medicine. We receive patients from all of the country, and the higher severity it is in our hospital. So till actual moment, we had around 500 patients, and the general mortality rate is around 24%. 1/3 of the patients are managed by non-invasive ventilation, but we have a limited possibility to keep all patients under non-invasive ventilation. We use also oxygen delivery through mask, and of course mechanical ventilation, prone position ventilation. We don't use already chloroquine or antivirals, but we use anticoagulant therapy like Clexan or Fraxiparin. And also during cytokinic storm, we use dexamethasone mainly, and methylprednisolone. Mainly patients have a lot of comorbidities like obesity, morbid obesity, diabetes mellitus, heart disease, and also we perform for patients with acute kidney failure, continuous veno-venous hemofiltration. Mortality rate among patients with mechanical ventilation, with intubation, is around 78–80%. And among the patients with terminal kidney disease is around 90% mortality. So there is a lot of work, and we are full all time. So in general, like general presentation is like this.
Okay, Professor Belli, thank you for your short summary. And I would like to proceed with questions for the experts. So first question is about non-invasive ventilation in COVID-19 patients. So do you practice it in Israel? In which patients? How you decide what are the indications? How do you begin the non-invasive ventilation?
Yes, we use various options of non-invasive ventilation in our patients. Obviously, it depends on their severity. As we've seen in the world literature, we try not intubate the patients because of the high rate of mortality with the ventilated patients. But once we see that the patients start to develop a tachypnea, that in my mind is one of the very important signs that the patient is going to fail the non-invasive ventilation and should be intubated before they crash. Particularly because the intubation, as you know, is a tricky process and a process that can potentially spread the virus to many of the healthcare workers. I would prefer to intubate the patients earlier. That's from the one perspective. The options that we've used as non-invasive ventilation, we use the high flow nasal cannula oxygen, only in obviously dedicated corona units, because also the fear of the high flow nasal cannula spreading the virus, and we use it actually at lower air flows than we would normally use it. We've also used face mask as well as helmet non-invasive ventilation with pressure support and PEEP. And we've also used a HIAC, the cuirass ventilation, which we've had good success with, mainly with weaning the patients from ventilation as opposed to preventing ventilation.
Okay, thank you. And the next question is about antiviral medication. What do you use now in your hospital? What is your protocol on anti-infective treatment?
Great. So from our point of view, in the beginning of the coronavirus outbreak here 4 months ago, we were giving chloroquine, we were giving azithromycin together and hoping that that would work. As you mentioned, that has shown to be ineffective. At one point, we weren't giving any antiviral treatment, but we were giving plasma from patients who had recovered from their coronavirus. We were giving plasma to the patients. I must be honest, I didn't see much of a benefit to that either in the patients. And in the beginning, we were giving also anti-inflammatory treatment in terms of tocilizumab, the anti-IL-6, and that also where we didn't see very good response to that. In fact, we saw more sepsis. And going more specifically to your question, over the last few weeks, we have been giving remdesivir to some of our patients with a very highly regulated process by our health ministry, where they need to okay the administration of the medication. Again, I have not seen much success with that. And after 4 months of treating the virus, I still think that good intensive care management of the patient, supportive care, is what helps the patients more than any specific drug.
I see a question on the side there from Professor Belli about the convalescent serum. So it's what Mark just mentioned. We did use it. In fact, we used it on a large number of patients. And we've had access to two kinds. One was plasma taken from patients who recovered. And we have quite a large pool of that plasma. And basically anyone who was on mechanical ventilation was eligible to receive that. We didn't see much benefit from that at all. And then more recently, there's a concentrated version of convalescent plasma, which we've used, and we used that in one patient, and so really can't tell you one way or the other.
Okay, thank you. I think that more or less the same experience with plasma we have in Moldova too. So we tried in many patients, but we really do not see any effect. At least any effect in case when we used it according to the recommendations of national authorities from the blood bank, national blood bank. Okay, and the next question is about antibiotic therapy. When do you consider it when you decide to start antibiotic therapy in COVID-19 patients?
Okay, as Mark said in the beginning, we were using azithromycin for the routine infection. That fell out of favor, and now we treat secondary infections in these patients. That's really what we look for. And we saw a large number of the patients that we looked after developed secondary infection, both in the lungs, also line sepsis and other kinds of sepsis. So we use the antibiotics appropriately for those conditions rather than for the virus itself.
What we have seen that the clinical picture is very difficult in the beginning to differentiate between a pneumonia together with the coronavirus. So we were using a lot more antibiotics in the beginning. With our experience now, we also know that C-reactive protein is very much a part of the COVID-19 inflammatory response and cannot be relied on to suggest infection. So we regularly take pus swabs, we regularly take blood cultures. We try and limit the antibiotics that we give initially. What we did find the first month or so of giving the antibiotics, the patients ultimately did develop secondary infections that were more difficult to treat. We had patients with vancomycin-resistant enterococci. We had patients with resistant Pseudomonas strains. So we tried to limit the antibiotics we give. And we have also seen that the patients who don't wean from the ventilator after 2 to 3 weeks generally will get a secondary infection, and then we'll go from infection to infection until we manage to control all of that.
Do you have any prophylactic approaches, any prophylactic treatment for the prevention of pulmonary fibrosis in COVID-19 patients?
Except for steroids, we don't give any other antifibrotic treatment. Our sicker patients, we have been giving them steroids almost from the beginning, despite the initial hesitancy regarding steroids. With a background in internal medicine, we like steroids. And with the recent article coming out about dexamethasone, we've changed our more serious patients to dexamethasone. And we're hoping that that will have a better effect to prevent the fibrosis. But I think the fibrosis happens very quickly. And then the patients continue to get infection after infection after infection. We have 2 patients currently in our medical intensive care who've been with us since the beginning. Pretty much they've both been around for 90 days. And they've gone from infection to complication of ICU. And I think that a lot of the issues in the lung is now due to their fibrosis, and therefore they're prone to recurrent infections.
I think some of the points Mark made is that these patients are long-term patients. They need weeks of ventilation usually. And when they recover from that, exactly as we say, it's not a simple recovery and they're better. They suffer from all kinds of things like profound wasting. You know, other organs are involved like the heart and the kidneys, and certainly the lungs take a long time to recover. And sepsis is a big issue in them. While I'm talking, can I address the question from Ruslan about tracheostomy? A lot of these patients get tracheostomized. In the patients that I looked after, we were doing them not as early as we normally do, just because of the practical issues. Right? Firstly, we do them in a particular manner in order to reduce aerosolization during the procedure, and we were doing them in batches, so that instead of doing one day and one the next day, so we did 4 or 5 at a time, in order to minimize the staff going in and out. I don't know if that answers the question.
Okay. And what about renal replacement therapies? What is your approach? Does it change somehow in the patients with COVID-19 infection?
It's a very good question. That our experience is that most of our patients did not need renal replacement therapy, which is different from what most other centers in the world have seen. We did, however, have patients on renal replacement therapy. In the unit that I was working in, due to staffing, we decided that we would not do continuous renal replacement therapy as it was too labor intensive. And we rather did intermittent hemodialysis. Even in the setting of a sick ICU patient, we made a decision to limit the workload, or lessen the workload on the staff. We did have 1 or 2 patients on continuous renal replacement therapy. As you mentioned, the outcome of patients who require renal replacement therapy with COVID-19 is not very good. Most of the patients did not survive. The one patient I mentioned now has been with us for 90 days. He is the only patient that we did dialyze and has actually been weaned off dialysis, and over the last few days even weaned off ventilation. But generally it's not something we've done. We also haven't used any of the filters that have been discussed on numerous forums to remove cytokines. There are numerous filters that can be added to the continuous or the intermittent hemodialysis machines, where numerous places have shown some success with a cytokine storm. We haven't used that in our patients at this point.
Yeah, and can we address the question from the psychologist at the top? See on the side?
Not at the top.
Yeah, the first question.
Yes. First question is about the psychological impact on healthcare workers, healthcare providers that are taking care about the COVID patients. Do you have any suggestions regarding the psychological support for the frontline workers?
Firstly, I mean, I've got a few words. I'm sure Mark has something to say about it as well. I think the effects on the staff are twofold. When the pandemic started, I think the major thing that we were dealing with was fear, probably. People not knowing what we were dealing with, the uncertainty of not knowing whether there were going to be 2 patients or 200 patients, the planning that went into that, and so on. So there was a lot of uncertainty and fear also about exposure to these patients and what you might take home. Right? So that's one aspect of it. The second one is that as this has gone on now, we're in the 4th month of it, right? There's added to all of those things, there may be less fear now because we're used to the work procedures and so on, but there's an element of exhaustion now. People are tired and it's not stopping. You know, every time when things seem to be calming down and maybe they open some more, lessen the restrictions on movement and so on, there's another sort of hotspot of patients breaking out. So the uncertainty remains, and now there's a sense of exhaustion. So there is support, I mean, certainly from the Ministry of Health here and so on, support for healthcare workers. But I think as clinicians, we have to be careful that our staff don't get exhausted and give them enough time to recover between shifts and so on. But,
I think thank you, Vernon. I think that addresses most of the issues that we have found with our staff. Over the last week, our staff have definitely been, many of them, both nurses and doctors, have been on the burnout spectrum. Some of our doctors and nurses have now tested positive for COVID-19, and I think that has put back the fear and the stress of the environment that we're working with. There's the added stress now of less staff and more concern that if they could get it, then the rest of us could as well. And I think from a psychological point of view, a lot of the staff, even one of the nurses today, who's generally a very positive lady, she was the one next to one of my patients while she died. And she was there instead of the family, because at this point, the family cannot come see her because they're also corona positive. And so our caregivers, as I'm sure you have as well, have had to deal with these end-of-life patients without the families. And that's taken a big strain on these nurses. And from a doctor point of view, where I enjoy the interactions with the families, that hasn't been there, and the families are constantly phoning every couple of minutes to get some information, and that's further draining us, that we are trying to explain to them, and we've considered different ways of Zooming them or videoing conversation with the patient's family so that we can at least bring them in together to the care that we're giving the patients.
Okay, and how do you think, in context of corona pandemic, should we consider to move our competencies from ICU to other medical specialty to the general, let's say, healthcare army?
in the beginning, when there was uncertainty about the numbers of patients that might present, we did a fair amount of preparation, exactly that, trying to transfer some of the skills, the critical care skills, from the intensive care sort of division or staff to the more general staff. Things like how to ventilate patients, how to use ventilators, and so on. But I think this is one of the lessons that we've learned, is that, for instance, providing a bed and a ventilator is not intensive care. It all comes down to the people. And it's not a skill that you can transfer in a very short time, in my view. So I think we're learning lessons now for what might happen the next time, to make sure that these skills get better disseminated among the general sort of medical and surgical staff, so they can be helpful the next time.
And I think the important emphasis in my mind is actually on the nursing staff as opposed to the doctors. With an intensivist overviewing a few doctors, I think that's adequate. But if the nurses are not adequately trained as intensive care nurses, all the treatment that we're doing around is inferior treatment, unfortunately. We've tried to merge different staff units together from internal medicine, from different departments that weren't working during the coronavirus. As, for example, some of the surgical departments closed, so they sent their nurses to us. And I think that the care was not as good as an intensive care nurse would give. And I think that the important point would be to continue nurse training on an intensive care level.
That's right. The other aspect of that is we saw a few examples here in the general intensive care unit when our more senior nurses were sent to the corona unit to take care of patients, that the patients here suffered, so that there's this secondary damage from the pandemic, and that usual care suffers somewhat as well.
Okay, and the next question is about anticoagulant and anti-aggregant therapy. do you use for patients with coronary artery stents?
Okay, Mark, do you
I think the patients with the stents, I would continue as normal practice, what they would need given the time that they have after the stent. I would definitely continue their anticoagulant treatment if possible. In terms of anticoagulation as a preventative measure, in terms of the hypercoagulable state that many of these patients have, in the beginning, obviously, we were giving treatment with clexane to prevent clotting. And over the last, I'd say probably 2 months, any patient who comes in with high inflammatory markers, we've started to give therapeutic doses of clexane from the outset. We have had patients who've developed strokes, ischemic strokes that have been 2-3 weeks after their initial presentation with COVID. We've obviously had patients with PE. And obviously we've had many patients with the intravascular clotting that happens in the lungs. And we've started over the last, say, month and a half to 2 months, we've changed our practice to give therapeutic clexane with follow-up of anti-10A levels regularly.
Yeah. I'll ask you a question. You mentioned about the markers of inflammation. Can you tell them what markers of inflammation we use routinely?
So what we're using since the beginning is we've been using D-dimers. The moment the patient comes in, D-dimers, CRP, and ferritin levels. Those are the 3 markers that we have readily available. And based on the extreme levels of those inflammatory markers, we've decided on the treatment options for our patients.
Just to finish that question there from Professor Bella about using anti-IL-6 and other sort of anti-cytokine measures. We had several trials going actually, and we used it open label in many of the patients. And I must say, anecdotally, I didn't see any benefit from it. And
we saw more secondary infection, I think,
yeah.
possibly. I mean, difficult to tell, but they did become infected.
Yeah, so there's an ongoing trial at the moment, but I actually wasn't keen and I refused to put my patients into it because I don't see a benefit. You know, if you look at what happens after with an inflammatory insult, you look at what happens to the cytokines, which go up and which go down, and how many of them there are. Trying to block one of them, I think, is a futile exercise. That's my view about that.
And we had a question about the feeding of the COVID-19 patients. Do you think they require some special feeding regimen, or it can be like any other septic patient? It can be fed like any other septic patient?
I think we treated them as we would any other intensive care patient. Used routine sort of mixtures like osmolite and other things.
Right. I did, however, in our unit, I found that a lot of the patients after a week or 2 developed an intractable ileus. And some of them complicated quite severely from that. And we were forced to be a bit more creative with our feeding regimens. Also, a lot of our patients were older, they were wasted already, and by the time we were able to feed them adequately, the major muscle loss, obviously hampering our feeding of the patients. But in general, we don't know, we've been given the regular amount of feeds, but I don't think we've been getting to the target because of the, I have a feeling that the virus affects the gastrointestinal tract as well, very possibly the liver. We've seen a lot of patients with elevated liver enzymes, particularly after a week of their major illness. And this also has to change the way we approach the patients.
I think that's right. I mean, this is a sort of multi-organ diseases. It's not single. The other thing that might be interesting is that pulmonary hypertension is quite common in these patients. It says something like 40% have right ventricular dysfunction, acute right ventricular dysfunction. And so we were quite liberal in the use of selective pulmonary vasodilators. I see it's also one of the questions up there. And we used two kinds. We had access to nitric oxide, but in our hospital we have something like nine devices for delivering nitric oxide, and we used those up very quickly. And so we needed to come up with another solution, and we used prostacyclin nebulized, which worked quite well. We saw good results from that. And that has the advantage also of being anticoagulant. So theoretically, it wasn't a bad thing to use by continuous nebulization.
Okay, and what is your opinion about ozone therapy as complementary therapy in COVID-19 patients? Do you have any experience with it?
No, except to avoid it. I don't mean to belittle it, but in this country, ozone therapy is very much a marginal type of therapy, which is not mainstream practice at all. And the only thing I know about it is to be careful with it because of that it can trigger severe bronchospasm.
Okay. And a question about pain management. What is your approach for pain management in COVID-19 patients?
Okay, I think it depends somewhat on which period of the disease we're talking about. So patients that are sedated and ventilated routinely get an opioid as part of their mixture, usually fentanyl, because as we mentioned, this is a long process. So using a short-acting opioid like remifentanil doesn't make much sense in the beginning. So fentanyl, midazolam, fentanyl propofol for sedation. And then after extubation, there might be minor pain issues, but I'm not aware of anything in particular. Just from being in bed for a month is enough to cause some sort of muscle pain. But, it doesn't require any sort of special attention, I don't think.
What we noticed is the patients need to be heavily sedated as opposed to the normal ICU patient who we wanted lightly sedated. The LDS patient, obviously, we want him to be deeply sedated. These patients required very high doses of sedation and required a long time, obviously, to wean from that sedation. Pain itself, in most of our patients, was not a big issue.
And what is your drug of choice for sedation?
We used either propofol or midazolam together with the opioid.
Okay. What is your opinion about the neuromuscular blockers? Have we to use them in case of COVID-19 patients?
Yeah, I think as Mark was saying, sometimes these patients needed such a high level of sedation that adding a muscle relaxant was the only option to keep them compliant with ventilation. The other thing is patients who were marginal in terms of oxygenation, despite all the things that we did, including mechanical ventilation, prone ventilation, nitric oxide, and so on, sometimes had to be paralyzed in order to improve compliance of the chest wall.
And what about lung ultrasound? Do you use it in daily practice to assess the patients, to assess the ventilation, to assess the pulmonary function?
We actually use it quite a lot in order to limit the number of times that we had to call the X-ray technician to enter the unit and have to get dressed and undressed and so on. So we didn't have as much access to plain radiology as normal, but we had access to the ultrasound machine. So we used that quite a lot, looking for things like inadvertent pneumothorax, pulmonary edema, pulmonary consolidation, things like that, pleural effusions. So it's quite helpful in that regard.
We were given an ultrasound machine that was slightly less optimal for intensive care purposes and took a long time to work. So I used it less, I'll be honest. I used to screen the patients for all their issues, liver, kidney, and lung issues about once in their admission. The rest of the time, we mainly used chest radiography is what we mainly used. But it's a very helpful tool. Unfortunately, also in a lot of patients, as we mentioned in the introduction, one of the risk factors for developing severe COVID is obesity and morbid obesity. And I found the ultrasound less helpful in these morbidly obese patients, and they made up a large majority of our patients.
Okay, can you address the question at the bottom of the page now about intubation, extubation, tracheostomy?
Yes, so the question is about the criteria for intubation and extubation. And the next question is about the time for tracheostomy, when we should consider the time for to put a tracheostomy inside, particularly from the perspective of proning the patients, how to care about the patients with tracheostomy if we have to prone them.
All right, perhaps if we go backwards, I'll address the question about tracheostomy and then you'll speak about that. So I think that's exactly the reason why tracheostomy is done a bit later in these patients than we're used to. Because proning the patients with a fresh tracheostomy is not a safe practice at all. So we waited for tracheostomy until the patient's no longer required to be prone. Okay, so when they were safe in the supine position on mechanical ventilation, that's when we consider tracheostomy. Because, as I say, fresh tracheostomy turning patients forward and back is very unsafe. But with regard to intubation, Mark addressed that earlier on about when patients look like they're failing. So,
what I would say is there's a lot of talk that we should wait as long as possible before intubating and ventilating the patients. If you have enough ventilators, my opinion is to not wait too long, because then the patient is less salvageable. What I found as a very useful marker is a bedside marker of tachypnea. When the patient starts when his respiratory rate is higher than 30, 35, chances are he is going to tire at some point, especially if he's older, and therefore one should intubate earlier. In terms of the proning position, we've started to use awake proning with limited success, as we've only used it in a few patients in the last 3 weeks. We would prone from the first couple of hours after intubation when we see that we have not managed to achieve adequate oxygenation. We would prone the patients. Obviously, that's also a very staff dependent procedure. If there are staff on the shift who cannot handle a prone patient, we would have to try and find somebody who could. It's not a procedure that one would use with their untrained staff. I think we became very good at proning patients, and in our unit we would prone the same patient probably every 48 hours. The immediate effect of proning is incredible to see the improvement in the patients. After 12 to 16 hours, we would put the patient supine, and that would generally last almost 24 hours, and we would prone them again. We generally did that for at least a week or so. Weaning the patient, I think, is according to any criteria of weaning other patients. A lot of our patients have required long-term weaning, which is why we've done tracheostomies on a lot of our patients. And then they've taken 2-3 months to wean.
I think the majority of the patients that I was involved with weaned by tracheostomy and not straight to extubation by any means.
And in terms of straight to extubation without a tracheostomy, we would always extubate to and assist a non-invasive form of ventilation, whether it's high flow nasal cannula, or we had quite a few cases where we connected them to the Curas, the Hayek ventilator, which is an external ventilator, particularly helps with their muscle weakness and their diaphragm weakness.
What is your approach to mechanical ventilation? Would you consider high PEEP, low PEEP, high driving pressure, transpulmonary pressure, high FiO2, low FiO2 level?
Okay, yeah. I think the general approach, maybe Mark wants to speak about specifics, but the general approach is that these patients, especially in the beginning, are fairly oxygen dependent. So the high FiO2 is required, whether we like it or not. People use relatively high PEEP, higher than in most other patients, between 8 and 12, that sort of range. And protective lung ventilation in terms of tidal volumes of 6 mils per kilo and trying to maintain plateau pressures below 35. I think that was the main approach that we used.
I would say it also very much depends on the patients. There's been a lot of talk of two different types of these patients. One is the normal, so-called normal ARDS that we see. And in those patients, we did give them the lung protective ventilation with 6 mils per kilo. The PEEPs were titrated accordingly. But then there were those other patients we found who had a compliance of over 40 centimeters of water, and yet they were profoundly hypoxic. And in those patients, we gave them what they needed. We found that those patients needed a higher respiratory rate, a higher tidal volume, even though it was above the ARDS protective lung criteria. When we tried to limit their volume, they were more hypoxic and didn't cope with that type of ventilation. But so we gave them a higher minute volume, and that enabled us to wean their oxygenation. And some of those patients also needed high PEEP. So I think with these patients, unfortunately, you're going to have to stay next to their bed and fiddle with the ventilator to find the right match for each patient and for each stage of his disease.
This is part of what I think, part of the learning curve with the condition, is there's a few very strange things that we see. The one is that you can have patients profoundly hypoxic with pulse oximeter reading, in the 80s, for instance, and they look asymptomatic. Patients look blue, but otherwise don't feel uncomfortable, which is a very strange situation. And then the other is these two phenotypes that we see. And I suspect that the second one, where the lung mechanics are not affected, is probably the hypoxia is related to intrapulmonary clotting. Yeah.
Okay, we have a question about the TAP in patients that are going to have the proning. So, do you observe a high incidence of TAP in association with prone position?
Don't know what that is.
Pulmonary thromboembolism.
Yeah.
Okay. Not that we have identified that there's been a high risk. I think that these patients in general had a higher risk of PE based on the inflammatory response and all the coagulation response that these patients have. We have had a few patients with PE. I don't think that it was any way connected to prone positioning.
The other thing is diagnosis of the condition is not simple in these patients, because the routine test that we do in these patients, sending a patient to the CT scanner, for instance, is not a simple matter because of the environmental contamination. So echocardiography is useful in these patients, looking at right ventricular dysfunction, for instance. But again, it takes a level of skill which we don't have on every shift, for instance, to do an echo quickly and easily. But I agree with Mark. I don't think that prone positioning per se is a risk factor.
What do you suggest to be used for assessment of fluid responsiveness in this patient?
Okay, again, so all the routine measures, clinical assessments, fluid balance assessment, looking at the JVP, looking at the CVP, but we found, again, ultrasound very useful in this situation, looking at the heart filling and IVC filling. It's a very simple sort of technique to put the probe on and look at the IVC and see how full it is. So that's a simple technique that we found very useful.
We also used, together with that, the passive leg raising test as a marker of our fluid responsiveness, as these patients become edematous very quickly. And it's difficult to determine their intravascular volume status. What I found is we need to become better clinicians as we're standing next to the patient, we don't always have all the good supportive evidence that we would normally have with the different machines and different tests. And we need to make clinical assessments of our patients, as difficult as that may be.
And a question about the triage. Which patients will come to ICU when there is not enough places, not enough beds, and free beds in ICU? How to decide who will go to ICU and who will stay on the ward?
You know, I'll start if you don't mind. Okay. It just happens that I'm involved with a group from Europe, okay, talking exactly about triage, and it's very interesting to me how the outlook differs between Northern Europe and Southern Europe, for instance, in terms of withdrawing care, withholding care, and so on. In Israel, we have an attitude that anyone who deserves care gets care, because I guess we're lucky in terms of having access to enough, so far, right, access to enough resources. So we haven't had to triage anyone, I don't think, at the moment. In fact, there's a 99-year-old on a mechanical ventilator right now, which
yesterday.
Yeah, which I can assure you in Norway wouldn't happen. Okay, so I think we're reasonably lucky. Now, I'm hoping the day never comes when we have, you know, five patients for one ventilator and we have to choose. But the Israeli Society of Critical Care Medicine has actually drawn up guidelines for triage. And I guess if we get to that stage, we'd follow those guidelines. But it would be a very difficult situation, and I hope one we never see.
Yeah, I think at the moment our triage is based on the baseline functioning of our patient's age. I think is just another one of the factors. This 99-year-old guy is a guy who lives alone. He's walks around. He's well cognitively, and therefore we gave him the chance. There have been others who have decided that we would not take, and I wouldn't take them to any intensive care units. I also feel that decisions on who gets the ventilator and who doesn't get the ventilator should not be left to us who are with the patients and have to see the patients. This goes back to the first question about the psychological well-being of the treating physicians. And I think that it is an easier decision to make if there is a board of people, including doctors, who need to be available to make such difficult ethical decisions. And I don't think that it should be only left to the poor doctor who's standing next to the patients, who then needs to decide who lives and who doesn't.
I think you're exactly right. The thing that I think you'll find in most countries is that this should be a societal decision, and one made by politicians and others. And the people furthest from these decisions are the politicians. If you, even in times of quiet, if you go to politicians and tell them they need to decide who lives and who dies, they run away from that question. So it's difficult. But to have an ethical board, for instance, that we can refer to, I think that's a useful thing, and that certainly is available to us if we need it.
Okay. Well, generally speaking, in Moldova, in society, there is a general view, or there is spread the idea that the coronavirus does not exist. Actually, that it's a fake story generated by doctors who are quite lazy and want to take the attention from the society. How is this point in Israel?
No, I think, again, we're quite lucky in that I think there's great appreciation, in fact, in society in general, for the work done by doctors and nurses in looking after these patients. There was an incident some months ago when at a certain time in the evening, all the population came out on the balconies and into their gardens, and at the same time applauded the medical workers for the work that they do. So no, I think there's great appreciation, and certainly not this attitude at all.
And at least in the first wave, we were inundated with food parcels and gifts, and everyone tried in their whichever way they could to support us and think of novel ways of assisting us from the society. One of the ministries here even made a stethoscope with loudspeakers, so that the doctors in the emergency room didn't have to use a normal stethoscope to examine the patients. It was the normal Bell stethoscope connected to a loudspeaker to try and limit exposure to the virus. So I think we felt very supported, at least in the beginning. I now feel like the disease is no longer a cool disease, and we're just left to treat the patients.
Yeah, novelty aspect is gone. Yeah.
Okay, what about any special considerations in pregnant or breastfeeding women with COVID-19?
It's actually a big consideration in this hospital, because what we've tried to do is separate the patients with COVID-19 from the general operation of the hospital. But occasionally we get patients who are pregnant or breastfeeding with the condition who have to be isolated, right? And that makes for great sort of logistic difficulties, because they get taken away from the services that are used to looking after them and put into places in the hospital where they're not used to looking after.
And how does the work in your ICU change during COVID? If there was any changes in organizations, in logistics, in flows inside your ICU that was produced due to COVID?
Yeah, there were certainly big changes in that. It took away resources from what from the usual care of patients. So we set up 2 separate intensive care units in a different part of the hospital, just for COVID patients, right? So that the general operation of the hospital would not be affected. So it was finding enough staff in order to set up these ICUs in the separate area, and the areas were not that we used were not built to be intensive care units. So there were great sort of logistic difficulties in working there. For instance, the air conditioning system wasn't adequate, the rooms were crowded, and so on. And we had to take staff from the routine sort of management of patients to look after that area.
But the result that we had to close our intensive care beds in our medical and the surgical intensive care unit. We had to close some beds because the staff were upstairs in the corona units looking after our patients there. And we also tried to limit staff contact, but with the fact that we were managing various ICUs, I don't think that we worked efficiently enough in separate teams. I think in Professor Van Heerden's unit, they were able to work in teams to try and limit contact with other teams, and therefore limit potential exposure of all the teams to the virus. My ICU has slightly less doctors, I would say, and therefore we weren't able to work as separate teams, and I think that's going to be problematic.
Yeah, what we did was, for instance, in 1 month, we sent half the staff home to be at home, to be available if we needed them. The other half worked for 2 weeks, and after 2 weeks, we sent them home and brought the first team back. So there was no contact between the 2 teams, in order to have a reserve team in case someone was exposed, and him and all his contacts had to be taken out of the hospital.
A question about elective surgeries. What we should do in order to be able to keep going with elective surgeries and not to cancel them at all?
I think probably the only way to do it is the way that we did it here, is to set up either a separate area for COVID patients or a separate intensive care area for COVID patients, so that your circle clean area can do its normal work, which is exactly what we did. So the surgical, elective surgery reduced by something like 2% during this time. And it didn't really affect it because, firstly, to be able to service that area of the population, and secondly, because it's very important economically for the hospital to continue to do those cases. It's a source of income from the hospital, so in order to remain viable.
And patients prior to surgery.
Yeah. So that was the other thing. We took all kinds of precautions. So any patient entering the operating room was tested before entering the operating room. And in the intensive care unit, if for some reason they hadn't been tested there, like an emergency case, for instance, they would be tested on admission to the intensive care unit. During all of this time, we only turned up, I think, 3 patients who sort of slipped through the net and were found to be positive later on, and were then sent to the COVID ICU in order to maintain lack of contact with the regular patients.
Okay. What do you think? What should be our focus in preparing for the second wave of COVID-19 infection? What should we do, or what else should we do in order to be ready to face this potential threat?
Okay, I think the preparation is multifactorial. You need psychological preparation. Okay, everyone needs to know that this is going to go on for months and months. It's not going to be over in a minute. So you need to prepare yourselves for the marathon. Second thing is to not forget the lessons that you learned during the first wave. Not be complacent. So to make sure that training continues, that gathering equipment continues. As you know, that the delivery time, for instance, for ventilators is weeks now. So if you order them today, they might be ready for the second wave, for instance. And to improve the procedures, the testing and the isolation and so on.
I would back that up and say that, as I mentioned earlier, I would continue especially to train the nursing staff. I would take nurses, and a lot of the ICU nurses have brought this to my attention, that they would be prepared for some of the nurses in the internal medicine wards, the surgical wards, to come and do a couple of shifts in the normal ICU to gain experience in treating and managing ICU patients so that they are ready for the next wave. As Professor Vernon said, just having a ventilator and a bed is very important, obviously, and we need to plan for it, but who's looking after the patient is more important, in my opinion, and therefore that type of training should continue. And I think what we're also learning here is don't be complacent. Now that all the society have opened up their borders and more younger people are getting infected now, more of our staff have started to get infected in the last 2 weeks. And I think it's because we tired and have become complacent about the disease. In the beginning, every case, we were concerned, we were scared, and I think that level has dropped. But I think that that's a problem. So we need to remain aware of this disease, be fearful of this disease, and therefore take the proper precautions with every patient.
It reminds me a bit about, HIV in the 80s. In the beginning, we were very careful and universal precautions, and then we got a bit more lax about it. We did it again with each of our exposures, H1N1 in 2009. Very careful. Now patients turn up with H1N1 and, it's kind of blasé about it. But we can't be blasé about this condition. It's very, very infectious, and it's kind of devastating when it takes out members of the team. I was reading the other day in Russia, for instance, they've lost something like 500 medical staff, doctors and nurses who have died from COVID. It's a huge blow to our sort of work society. We have to be very careful.
How do you manage the emergency cases, patients that go for emergency surgeries? Do you consider them to be suspected with COVID-19 infection? Do you approach them as positive, negative patients? Would they go to the general wards or to some special wards?
Okay, so what we do is we treat every patient as a possible positive patient. They get tested before entry to the operating room if there's time. If it's an emergency case, there's no time. As we said, they get tested immediately afterwards. All precautions get taken, especially during airway manipulation. So during intubation, N95 mask plus face shield plus gown. Okay, for the staff during extubation, the same. So we take all precautions. If the patient is really suspected, they get isolated until they're tested. If they test positive, they get put into the corona ICU. If they get tested negative, they get into the regular ICU.
Newborns in COVID-19 positive mothers, are they, does this newborn stays with their mothers, or are they isolated somehow?
I don't actually know.
Yeah. I don't know if
do you know anything?
If
Mothers and newborns are isolated.
actually, yes, unfortunately, in this hospital, they isolate when they.
But together?
No.
Okay, they're separated.
They separate.
Okay.
And even World Health Organization recommends otherwise.
Separated.
In this hospital, no, they recommend not separate, not separation, but still in Adasa we separate.
Okay.
So, did you have any cases of reinfected patients in ICU?
I'm not sure I know what you mean by reinfected.
I guess that a patient that was considered to be treated, to be cured, and after that is coming back with a second COVID-19 infection. I think this is the question.
Yeah, I don't think I've seen any.
We haven't seen patients reinfected like that. What we have seen, particularly with elderly patients, we've seen that they take a long time, even 2 months before they are tested negative for their COVID-19. We routinely do tests once a week, if not twice a week on some of the patients, and very many of them remain positive. So I don't think that there is a reinfection. I think a lot of the patients either were falsely negative or they never become negative, or it takes 2-3 months before they clear the disease. I also believe that the COVID probably sits on their tracheostomy or on their trachea itself, and they're not infectious, but they still are positive when we do the PCR testing.
I've seen some reports in the literature about that immunity is supposed to last only for a short time, but it's really 1 or 2 reports. I've not seen it as a statement of fact. So that immunity only lasts for 3 weeks, and then you can get reinfected. But in practice, we haven't seen that.
What some of the doctors who've been monitoring the convalescent plasma have found that many patients don't develop any immunity. And that was, I think, one of the problems with the convalescent plasma is the dose was not a regulated dose, and it depended on who the donor was, whether we really had good antibodies or not, and not everybody develops good antibodies.
Do you think that a vaccination campaign can be a solution in the context where the immune response is not very straightforward, and in case when we do not really know if if immune response is lasting for a long period of time?
Yeah, and look, I think there's many questions about vaccination. I heard the other day there's something like 200 programs around the world of people making vaccines, and the uncertainty is exactly as we're saying with this. We don't know what the response will be to the vaccine, how long the immunity will last, what the side effects might be, and so on. But having said all that, I think it's our only hope, really. You know, without widespread vaccination, you need to cover apparently something like 60% of the population with the vaccine before there's enough herd immunity. But I think until we do that, we're going to see this disease in the background.
Okay. Are there any other questions from the audience?
While people are writing the questions, if there are any questions, I would just like to mention another point that we've started to consider now is the post-COVID-19 respiratory disease. Most of these patients who've survived ICU are respiratory cripples. We're in the process of opening up a clinic run by the pulmonologist. We will be able to then monitor these patients, and we're expecting an upsurge in the number of patients who ultimately are going to need transplants within the next couple of months to years. And it's very important that even the patients who were mildly infected continue follow-up with a pulmonologist, as numerous of these patients have significant fibrosis and they need to be managed long-term.
Okay, thank you. And Dr. Baltaga showed me that he would like to say something. Dr. Baltaga, please.
First of all, thank you very much for all participants to this very useful and informative webinar for us. I just want to conclude with some info for our colleagues, especially from Israel, but from Moldova as well, about Medical Foundation and what was our effort in this pandemic. The Medical Foundation Valeriu Gheric was established at the base of chair of anesthesia by disciples and colleagues of late Professor Valeriu Gheric, who was the founder of the chair of anesthesia. And we have initiated a campaign, Country Needs ITU, that was inspired from Romanian Society of Anesthesia, Professor Dodo Sendesc, who launched the campaign Romania Needs ITU. So we have three directions in this campaign. First was to attenuate the wave and to reinforce the capacities of medical staff to protect. In this view, for example, we didn't have any video laryngoscopy in the country, so we managed to have some donated, some funds reallocated. So we found the video laryngoscopes for this. Especially for big hospitals. Then other activities like transportation for staff who live in suburbs, as well accommodation for staff in ITU who were scared to go home and for their families. So that was first big compartment. Second was the testing and screening of staff, because everyone was, scared about getting infected, especially and get infected for the families. So we've done screening testing. Now hospital does this. And third direction was to reinforce the treatment strategies, like prone position. We were fundraising special devices, cushions. Ultrasound machine, we fundraised for ultrasound machine, and now we have in department an ultrasound machine and other therapies. We were contributing as well. Professor Belli can confirm that in COVID unit, and Dr. Kesov as well can confirm that in COVID union, as joint effort of different stakeholders, chair of anesthesia, department of anesthesia, foundation, we managed to have less infected staff than outside COVID departments. And of course, one of our directions is education, which is constant. And again, I would like to thank for your participation. With Israel, we have very, very good connections. Me personally and Professor Bela as well, we benefited from a project of WFSA back in 2002, and we stayed in Beersheva. Many colleagues, professor, speakers attended our conferences and congresses, and I hope for future we will have more close cooperation with you as well. And thank for our colleagues who are in your hospital, and I hope they give you a good hand and they made connection with you as well. Thank you very much, and wish everyone to stay healthy and keep doing the best we can do.
Thanks very much. I just had a short statement as well. Before you said it, I was going to say that we've had very good experience with the doctors from Moldova. especially Elena and Roman at the moment. And send as many as you like, as long as they're good as these two, okay? And one last request. You've been seeing our picture all the time. Can everyone turn on their video for a second so we can see you before we go? Yeah, where the rest of you?
You want, it doesn't work video.
Okay.
Okay.
And not again.
All right.
Go well and keep safe.
Thanks for the invitation, and we'll speak to you again, I hope.
Yes, with pleasure.
Thank you. Thank you. By this, I would like to close our webinar. Finally, at the end of the webinar, my camera started to function. I would like to thank you, Professor Vernon, as well as Dr. Romain, for your participation, for your willingness to share your experience with us, and hope that we will be able to continue in future our collaboration, not only in the format of webinars. Thank you very much once again. Goodbye.
Thank you. Bye.
Bye.
Thank you.